Blount's disease is actually one of the very common cause of genu-varum. It is a progressive pathological genu-varum centered over the tibia. What actually happens is, in the case of the Blount, there could be two forms of Blount's disease. One is infantile Blount's disease and other is adolescent Blount disease. Usually infantile Blount disease affects early children at the age of 2 years, 3 years, up maximum up to 4 years of age. This is when it presents with a pathological problem very early on over the tibia. And one has to understand the problem is with the proximal physis of the tibia. And then there is adolescent, which actually affects age usually after 8 years of age, may usually present at 10 or 11 years or 12 years of age as well. This is actually a very less common form, which is also called as adolescent Blount's disease. What happens in Blount's disease? Actually, the problem starts with, it could be unilateral or it could be bilateral genu-varum as well. A child of, let's say, 3 years of age comes to you with a bilateral bored legs. Now, by 3 years, as I told you, physiologically, the genu valgum peaks at the age of 3 to 4 years. So if a child of, let's say, 3 years is coming to you with bored legs, this means there is some pathological process which is going on. This could be, you have to roll out, get the detailed history, and as well as do the detailed clinical examination to rule out the rickets, osteogenesis imperfecta, and the skeletal dysplasia. But if it comes out, diagnosis comes out to be there is no history of trauma or any physical injury, but the problem is actually the infantile Blount's disease, then you have to also assess certain other things which are related towards the Blount's disease. For example, the problem in the case of the Blount's disease is actually the proximal tibial physis. There is a Langen-Scalod classification which is there, and it's divided into grade 1 to 6. From grade 1 till 2, there is from grade 1 till 4, you have actually mainly the physial tethering and sloping of the side. So if you look at this, the problem is actually with the medial side of the physis. But from grade 5-6, there is actually formation of physial bar, which actually results in progressive genu-varum, which may be bilateral as well. Therefore, when you are assessing the Blount's disease, first you have to classify whether is it infantile or is it adolescent. Usually with the risk factors which may be associated with infantile Blount's disease could be there's more commonly seen in males as compared to the females, the usually male children. Then there's more common in African and Hispanics, and then as compared to the Caucasian whites, and then it's also that usually associated with obese and overweight children. So this all factors actually increase the propensity of developing Blount's disease. Main problem is usually actually the overload or mechanical biomechanics. So the mechanical overload leads to depression of the physis, eventually leading to molding into genu-varum. Certain individuals are more genetically susceptible, and when the mechanical overload happens, this leads to deformity in form of a bored legs or bilateral genu-valgum, in which may be the reason that usually not all children who are obese develop infantiles, but those who are genetically susceptible, if they are also obese, they develop infantile Blount's disease. If you once you have diagnosed after taking detailed history and examination, you have to get certain x-rays of the knee joint. Preferably both knee joint x-rays should be taken. But if you would get an x-ray, this is something we would classically see. This happens to be the lateral side. This happens to be the medial physis of the proximal tibia. You can very well see how much tethering and scalloping is been sloping of the medial tibial physis is there if you compare to the lateral side. Now this would actually, the slope and tethering would result in further eventually aggravate into formation of physial bar. Once the bar is formed, this means there is no growth can take place at the medial side. A growth at the lateral side would further lead to increased genu varum. Therefore, you have to have a Lange's classification. You classify them from grade 1, 2, 3, 4, or even 5 or 6. When the bar is there, this either it's grade 5 or grade 6. But usually facial tethering and sloping is usually seen till from grade 1 till 4 as well. Then when you are treating this disease, you have to again keep it in mind that once you made the diagnosis, there are certain things which you need to remember, that what is the age of the patient and what is the grade of the Blount's disease. Treatment mainly actually depends upon that you have to get a preoperative arthrogram in form of where you get a proper view of both knees. You assess the Drennan angle, which could be metaphyseal epiphyseal angle, and if it comes out to be more than 16 degrees, there is a 95% chance that this will further progress and eventually the grade of the will increase. If the Drennan angle, which is the metaphyseal epiphyseal angle, is less than 10, therefore there is a 95% chance that it will resolve spontaneously. So first you have to calculate how much genu varum is there, what is the Drennan angle, what is the age of the patient. If age of the patient is, let's say, less than 3 years and Drennan angle is also less than 10 years, then you probably either you don't need to do it, or if it's grade 1 or 2 Blount's disease and age of the patient is less than 3 years, we can go for KAFO, or that is knee ankle foot orthosis. This is usually a form of orthotic bracings which can be given to a child to prevent further aggravation of genu varum, and usually as the Drennan angle is also in acceptable limits, probably this is going to resolve spontaneously over the years. But if let's say the grade is 3 or more than 3, that is 3, 4, 5 or 6, age of the child is more than 3 years of age, or the child has failed bracing, then probably we'll have to go for some form of corrective surgery, that is an osteotomy at the proximal tibia. As the problem is actually at the tibia, therefore we have to go for a valgus closing wedge valgus osteotomy at the proximal tibia fibula. And usually when we are going for that, we overcorrect it to some degree. Why? Because the physis has actually will still continue to grow, and there will be some form of a tethering over there as well, but this will further lead to some once if we have not overcorrected it, by the time child becomes 6 or 7 years of age, there may be some residual genu varum which may be present in form of a deformity still at the knee joint. Therefore we have to overcorrect it up to 10 to 15 degrees, so that once even if some residual genu varum does forms, this would actually result in a normal biomechanics at the knee joint. Other options could be a laser off method, that is, instead of completely correcting by an osteotomy, we correct it gradually by we do the corticotomy at the proximal tibia, and we gradually deform the bone in such a way that it's not only corrects itself gradually, as well as actually the bone sorts of heals along with it as well. Sometimes, not always, but with the osteotomy you may or may not require a fasciotomy, because sometimes the deformity may be so much that actually when you are correcting it with an osteotomy, this will predispose the patient to compartment syndrome. Therefore you may require some form of fasciotomy, but usually it's not done along with that. Most commonly, mostly if it's grade 1 or 2 and age is less than 3 years, we go for KFO. If it's any other grade, age is more than 3 years, and if it's failed bracing, we go for some mostly form of corrective osteotomy. A laser off method is also one form of a correction. Instead of going for osteotomy, we can go for this and gradually correct the deformity over the period of time, rather than along with the weight bearing, and patient can bear weight and continue this daily activities of living, and then get the correction over the periods, like let's say from 1 to 3 months of 6 months over the period of time.